Good morning, everyone, and welcome back. I'm still John O'Brien, Deputy Assistant Secretary for Health Policy here at ASPE, and welcome back to day 2 of the PTAC meeting. I know you all had a very productive day yesterday discussing 2 proposals, the hospital at home proposal submitted by the Icahn School of Medicine at Mount Sinai, and the Advanced Care Model Service Delivery and Advanced Alternative Payment Model submitted by the Coalition to Transform Advanced Care. I'd say there were a number of interesting firsts yesterday. I continue to be excited by the quality and depth and unexpected nature of the discussions that we had yesterday, and I'm sure today will be just as productive and exciting. I know there's a 3rd proposal to discuss today, the Oncology Bundled Payment Program using CNA-Guided care submitted by Hackensack Meridian Health and Coda Incorporated. We're looking forward to the results of your deliberation and voting on this proposal as well. The Secretary will shortly be posting his response to PTAC's comments and recommendations on the CMS website, and they will also be posted on the ASPE website. I don't know if it will be by the conclusion of my remarks at some time during this meeting. I can't discourage you from refreshing your browsers and missing the conversation that's happening here, but I do believe that they will be posted very shortly. And as the statute directs, not only are the responses posted, but I also just wanted to share a bit of insight and be sure that the following messages are clear. The Secretary has a great deal of appreciation for the submitters, those who have carved time out of their hectic practice schedules to develop these payment models. It's a testament to their dedication to the profession that they've crafted these proposals to improve outcomes for patients across the country. The Secretary expresses his thanks to the PTAC members for the incredible amount of work that you put in evaluating these proposals and advising the Secretary on the challenges and opportunities that these models may represent if tested and put into practice. He knows that you have day jobs as well and that this work requires a lot of time and effort. Your expertise and willingness to use that knowledge and serve as members of PTAC is a testimony to your commitment to improving U.S. healthcare. And again, thank you for being here. Related to the first 3 proposed physician-focused payment models, some messages from the letters may be worth calling out this morning. The Secretary was clear about several things. I think one is he doesn't want to hide the ball. The letters are intended to be very clear in what he either finds exciting or concerning in the proposal. For example, there's a reference to a concern about proposals that rely on a particular piece of proprietary technology in order for the model to be tested or successful. It's also concerned about proposed models that may only be implemented by the submitter. The Secretary is most interested in proposals that many physicians and patients could benefit from. Over 900,000 clinicians, including over 500,000 physicians, deliver services worth over $70 billion to 50 million Medicare beneficiaries a year. So the Secretary is looking for ideas that many physicians could participate in and help those beneficiaries, not just individual submitters. Proposed models that include particular proprietary items or that are tailored to work only for one practice or hospital or only for the submitter will not be as effective in achieving the outcomes we desire. And while HHS is interested in broad models that address quality and payment, it does not plan to pursue models that mainly involve testing a particular form of proprietary technology or that are focused on implementation only by the submitter. So I think those are some key themes from the letters that will shortly be posted. I know the Secretary is looking forward to receiving PTAC's comments and recommendations on the proposals discussed this morning. He's received a download of what happened yesterday, and I know that you all have a very busy day ahead of you and flights or trains, what have you, to catch this afternoon. So I'll thank you again and wish you the best for a great meeting. Thank you.
Thank you, John. So my name is Jeff Baylett. I am the chair of PTAC. To my left is Elizabeth Mitchell, and we will ultimately go around the room and introduce ourselves. I just wanted to walk through the process today very quickly. As John said, we are going to be evaluating the preliminary review team's work and looking at the proposal on the oncology bundled payment program using CNA-Guided care, which was submitted by Hackensack Meridian Health and CODA Incorporated. The first part of our meeting is going to involve where individual members will make disclosures with potential conflicts of interest. We will then turn it over to the lead for the proposal review team. They will review their analysis. They've been working very closely with the submitter to thoroughly evaluate the proposal. The committee will then have the opportunity to ask clarifying questions of the proposal review team, and then we will invite the submitters up for their presentation. The committee will then have the opportunity to dialogue with the submitters directly. And then finally, before deliberations, the public will be invited to participate in the discussion. And then the next part of the process, as John said, is really the deliberative process. The last point I'll make, I think, which is important to know, is that the discussions you'll see today are the first time that the committee has discussed this proposal. With the exception of the proposal review team, there has been no discussion among the members of the committee relative to this proposal at all. All of our deliberations are required to be done in public. So today, as we hear from the review team and then start to discuss and ask questions amongst ourselves and the submitters, this is all going to play through, if you will, live. So I just wanted to make that point. And I think at this point I'd like to start with you, Tim, on this side of the room. If you could just start introducing yourselves, we'll go around.
Tim Ferris, Mass General Hospital in Boston.
And the conflicts of interest, maybe we can do that at the same time.
And no conflict.
I'm Harold Miller, President and CEO of the Center for Healthcare Quality and Payment Reform. You surprised me on the conflicts here. I do have some things to disclose. I don't believe they are conflicts, so from 2013 through early 2015, I did provide some fee-based consulting assistance to the American Society of Clinical Oncology, ASCO, in developing a payment model for oncology care called patient-centered oncology payment. I have not received any consulting fees from ASCO in over 2 years. I have no future involvement in the PCOP model. ASCO did reimburse me last year for travel, for attending and participating in 2 meetings in which issues related to value-based oncology care were reimbursed. There were no fees involved with that. In April 2017, I received a small honorarium and travel reimbursement for giving a presentation at the Florida Oncology Society annual meeting, in which I described opportunities to improve quality and reduce spending for cancer care, the need for new payment models to support better cancer care, and several different approaches to payment, including the CMMI oncology care model and the patient-centered oncology payment model. I do not have any financial relationship with any organizations or individuals that produce or deliver oncology care services or products, and I do not know anyone from Hackensack Meridian Healthcare or CODA. So I do not believe I have any conflicts, but lots of stuff to disclose.
Paul Casoundier, Presbyterian, nothing to disclose.
Bruce Steinwald, health economist with a small consulting practice in Northwest Washington and lots of government service before that, including a stint in this building in the first Reagan term. Nothing to disclose.
Ann Page, staffed the PTAC and also the designated federal officer for this FACA, Federal Advisory Committee Act committee.
I'm Mary Ellen Stallman, ASPE staff and the staff lead for PTAC.
Elizabeth Mitchell, President and CEO of the Network for Regional Healthcare Improvement, and nothing to disclose.
Lynn Nichols, I'm a health economist at George Mason University, and I have nothing to disclose.
Hi, Kavita Patel. I'm a physician, and I'm at Johns Hopkins and the Brookings Institution, and I don't believe it's a conflict, but I had a disclosure, and I realized I couldn't put proper grammar together, so I wrote, I have not conflict, but I have no conflict, but I have heard CODA present, and I've also heard Dr. Pecora and others who have talked about the similar concepts, but not exactly this payment model.
I'm Bob Berenson. I'm an Institute Fellow at the Urban Institutes. I have nothing to disclose.
I'm Dr. Rhonda Meadows, Executive Vice President, Population Health, Providence St. Joseph Health. No disclosures.
And as I said, I'm Jeff Baylett, the Executive Vice President of Healthcare Quality and Affordability with Blue Shield of California, and I have no disclosures. So at this point, I'd like to turn it over to Tim, Dr. Ferris.
Thank you, Mr. Chairman, and members of the PTAC committee. I'm here to represent the preliminary review team that was Bob Berenson and Bruce Steinwall were my collaborators in this, and we were ably assisted, and thank Ann Page for staffing our preliminary review team. I think my first obligation is to remind the public what our process was. The PRT was assigned, including by the chair and vice chair of PTAC, to serve on each complete proposal, and I was selected to serve as lead reviewer. The PRT identifies additional information needed from the submitter and determines to what extent additional resources are needed. We review the proposal. Additional information is provided, including public comment. We review all that material and create a preliminary report. The report was posted on the PTAC website like 2 weeks prior to this session, and then subsequently our deliberation by the full committee. Importantly, the PRT report is not binding on PTAC. It is a preliminary review and is intended to be the source of discussion for the PTAC deliberations, and that the PTAC may reach different conclusions from that contained in the PRT report. So I'm now going to go through the model overview. And let me start off by saying, relevant to John O'Brien's comments that we just heard, that this proposal was explicitly written as a pilot for Hackensack Meridian Health and CODA. And we'll come back to that point, I'm sure, during our discussions. This is a proposal. It's a bundled payment for care with patients with newly diagnosed breast, colon, rectal, and lung cancer. The proposal has some significant clinical and payment complexity related to the hierarchy of conditions, bundles, something called CODA nodal addresses, CNAs, which is an aggregator, a classification system of demographic, biologic, and treatment factors. This is, the CNAs are part of a proprietary software package, or they are manifest in a proprietary software package. In this system, each patient is assigned a CNA based on demographic, biologic, and treatment factors. Only patients with an identifiable CNA in this system are enrolled into the payment model. Each CNA has multiple treatment lanes. The lanes is the word used in the proposal. We assess these as being very similar, if not identical, to what has traditionally been referred to as care paths. Or pathways in which, over the course of time, the treatment protocols, diagnostic, not just treatment, but all of the care protocols, are highly defined in these lanes according to the original designation of the CNA and the specific lane chosen based on such things as treatment preferences. So in the last line here, physicians and patients choose the treatment lane from among the options within a CNA. I will say that this description, I look forward to the submitter's response to this description. This is a very high-level description of what in the proposal was a very complex model. And so if this misrepresents that, I look forward to the clarification. The bundles cover 1 year starting on the day of pathologic diagnosis of cancer. I'll come back to the point about the initiation point, the day of pathologic diagnosis. Prospective bundle payments, including cost of oncology care and unrelated services. There was some, as we'll talk about, some ambiguity around whether or not this was a total cost of care model or a oncology-only model, and we had some discussions about that with the submitters. Not sure we came to full resolution of that. The HMH proposal to work with CMS using historical claims on HMH patients to estimate the Medicare 12-month cost for each CNA. This is a very important point. This is the method by which the pricing of the bundles was to be established. We're going to talk about that again some more when we get further down. And then, as we understand it at the highest level, the costs of each CNA will be aggregated up to the bundle level using a weighted average approach. These would be used to compute a prospective 12-month price for each of the 27 bundles within each of the 4 diagnostic categories in the 4 cancer types. And the recipient of the payment, in this case HMH, would be paid an amount that would be the sum of the bundle price and the number of patients in each bundle. The case mix adjustment occurs as a natural consequence of that arrangement because of the second piece of it's the bundle price times the number of patients in each bundle. If you have a different number of patients in a particular bundle, that would, by in and of itself, adjust for the case mix in the bundle. So to continue, the HMH would receive the prospective payment and use them to compensate providers and pay for care coordination and other uncovered services. So very importantly, prospective payment model. They'll be at risk for costs of delivering care if costs exceed the prospective bundled payment. This has different implications if this is an oncology-only model or a total cost of care model. At the end of 1 year, the bundled payment will no longer apply to an enrolled patient. They now fall out of the bundle ends. The proposal requested a stop-loss arrangement. Won't go into the details. Once a patient is enrolled in a bundle, all claims billed to CMS from any HMH-related provider will be forwarded to HMH. HMH will then pay those claims and pay physicians based on the standard fee-for-service Medicare rate. This proposed process was somewhat novel to us, and we could imagine, as a PRT, we imagined some interesting potential complexities involved with completing that. Part of the compensation to physicians would be incentive-based. This was something that would be sort of below the external payment line, so how they would handle the money internal to the organization. So an important slide, and this slide was not in for the people in the audience, this slide was not in the group of slides that was posted last week or so, whenever this stuff was.
But it will be reposted, so these will be made available.
These slides will be available.
And they were sent out to participants, so the new slides should be in people's inboxes.
In people's inboxes, thank you. And this is pertains to the statements we heard this morning. So given unresolved questions at the time that the PRT did its review regarding the acceptability of a recommendation for a single site proposal, the PRT proceeded with the review assuming a single site proposal would be acceptable. Our evaluation against criteria was for a single site pilot because that's how this proposal was written, and not for a deployable national model. And the third point is, given unresolved questions regarding the acceptability of payment model that relied on proprietary software, the PRT proceeded with their review assuming proprietary software would be acceptable. Okay? So, coming to the summary of our PRT review, you can see here, I won't read through this, all of our conclusions were unanimous. We believed against the criteria applied to this single site pilot proposal. We believe this met criteria with all except for patient choice. And with 2, we thought it met criteria with priority. So now I'm going to go through criteria by criteria. So on scope, I think the protocol is that I'm supposed to read the criterion just to make sure everyone's on the same page about this. The proposal aims, so in considering criterion 1, does the proposal aim to broaden or expand CMS's APM portfolio by either 1, addressing an issue in payment policy in a new way, or 2, including APM entities whose opportunities to participate in APMs have been limited? So we looked at this in a couple different ways. The first was cancer costs have the highest growth rate for any clinical area for several years, and that is predicted to continue. So this is a very important area to have alternative payment models for. And although CMS's oncology care model already addresses this clinical area, we found several aspects of this model to be novel and potential improvements over OCM. And so that statement is the principal reason why we thought this met the criteria. If the model requires the use of proprietary software, this could limit its uptake. So this gets, again, there's the scope, the proprietary issue affects the scope question. As written, the model is not generalizable. We did not think this was a model that was ready for going public on a national basis. There were too many questions, as we'll get into in the payment model, that were unresolved. Although we found some very attractive aspects of the proposal, as we'll get into. Overall, assuming concerns could be overcome, the proposed model would be a valuable addition to CMS's portfolio. Criteria number 2, quality and cost. So here on the strength side, the treatment pathways, the lanes contained in this system, and the specificity with which the CODA nodal address is defined by very highly organized and highly specified patient demographics, diagnostic testing. We thought this was quite innovative, and because of the precision of the diagnosis and treatment and the lanes created for the subsequent care of the patient, that this was very likely to have a high degree of to reduce variation in the treatment of cancer patients. And so this was a very attractive piece of this. We also thought people, as members of PTAC know, in bundled arrangements, there is a concern about entry into the bundle in order to take advantage of the bundled payment. We found that the specificity of criteria for entry into this really dramatically mitigated any potential gaming of a bundled payment around this, because you either fall into the criteria or you don't, and it's completely auditable and highly specified. So we found that to be a particular strength. And we also found it patient unlikely to end up in the wrong bundle given the specificity of the assignment. So we considered these strengths and reduced the potential for gaming of a payment model. On our concerns, we were concerned about how patient preferences impacted lane assignment. I'll get back to that. Verification of the pathology and stage, possibly through a clinical audit process. There wasn't much detail in this proposal about this. Dr. Berenson had brought up during the PRT that there's actually considerable literature about misdiagnosis in cancer. And so we did have some concerns about what the audit process should be in this proposal, in such a model. And then, and this one was particularly challenging. Assessing the proposal's impact on cost was quite challenging for us. It depends largely on the prices, and the method for determining the prices in this was a single site method, which bakes in the practice of care at that single site. And so that was problematic for us. Nonetheless, as we wrote here, the prospective nature of the payment method should result in more predictable costs for CMS and should reduce variation in costs. So anytime you have a prospective payment model, you should expect those things to happen. Cancer care, and then our last concern was cancer care changes really rapidly. It's unusual for a month to go by in which one of the major journals in the United States doesn't actually have a paper that suggests a significant change in what the protocol is for a particular type of cancer. That's how rapidly it's changing. And we did have concerns about the speed with which the software was being updated and updated appropriately. So getting onto the payment methodology, and here I beg your indulgence. I'm gonna bog down a little bit here. This is quite complicated, but we'll get through it. So first, on the benefits, 4 aspects of this model, as we've already stated, we found particularly strong. The cancer stage was included in the grouping. This was the thing because there's been quite a bit of literature that suggests that the failure to include stage in bundles, the difference between a stage 1 cancer and a stage 4 cancer is like the difference between, you know, a heart attack and an autoimmune disease. I mean, they're really not even close to the same thing. And so to include them in the same bundle sort of begs a lot of questions about case mix adjustment and presentation and variation in the bundle. So this proposal really fundamentally addressed that known problem with cancer bundles. The 1-year time frame was also, we found that an attractive feature. The inherent case mix adjustment that comes along with the way this is done, and the prospective payment, all of these, as I've said, we found positive. The concerns. You know, I probably won't list all of these. These are available for everyone to read. But we had a lot of concerns, just things that could not be answered without doing some sort of pilot or test of this model. So the low frequency of some of the CNAs, how would that affect the accuracy of the prospective prices? Will historic data accurately represent unit costs in the prospective model? How will the model handle leakage of both patients and doctors? How will savings be calculated, and will they be valid estimates? If it's an oncology costs only model, how will oncology costs be isolated? That's a tricky thing to do in claims. I'm not sure that I've seen a successful demonstration of that. Pricing the non-cancer services, as it follows from the prior point, is problematic. The mechanism for initiating the bundles was not well specified in the proposal. While it was well specified in the concept was well specified, but actually the practical issue of what is the communication between the participant and CMS that actually triggers that what was not clear. And we could think of several different ways of doing it, but these ways have not, to our knowledge, been tested. And the model proposes to exclude outliers. As a small matter, we considered Windsorization a better approach to the outliers. So criteria 4, again, we said this met the criterion. So I should say, we said this met the payment methodology criterion. We said it met the criterion because we were evaluating it against this as a pilot, as a single site proposal, where we thought it's possible in a pilot you could work all this stuff out. I think it's fair to say, and I think I will look to my PRT collaborators, that these are not questions you would want to work out as you scaled something at a national level. Criterion 4, value over volume. We thought, again, the prospective nature and base, I'm not going to repeat the comments, they're similar to previous, about why this is, would produce value over volume. In terms of our concerns, we did have some risk of patients, while you said there were some strengths about gaming, I mentioned earlier, there was one potential weakness that was unresolved in our minds, which was if a doctor saw a patient and that patient, say, was particularly sick, and they actually fell into they did match a CNA, how does one know whether or not the physician just simply didn't sign them up for the program? What is the audit process by which one, so there is a potential method by which you could select patients out of this in a way that advantaged the participant. And we just didn't, we could imagine ways to solve that problem, but we didn't, they weren't in the proposal. And then the mechanism, we thought it was very plausible that costs would be reduced in a prospective payment. You get a prospective payment, you got to manage under that. We thought it was very plausible that costs would be reduced, but they did not actually specify the mechanism by which they thought costs would be reduced in the proposal. On balance, though, we found these risks balanced. Flexibility, again, we thought it met criteria, but there's a nuance here. If the CODA software is required for the model, then the proposed model, one would think this actually doesn't provide much flexibility to the practicing physician. On the other hand, we thought that the high number of CNAs and the specificity, that was actually a strength of the proposal, that in fact, one of the things that's a problem that we're trying to address in US healthcare is the extraordinary variability. And if the specificity of this is as presented, in fact, the reduction in variability, despite the constraint on flexibility, would be a positive. But one caveat, one important caveat to that is, there's always situations that arise in clinical practice that doesn't fit the model. And if a patient doctor dyad decided that it was actually in the best interest of the patient to disagree with the recommendation of the software, what's the path for that? Is that included in the bundle? Is that not included in the bundle? And so those were our concerns related to the specifics of the mechanism, assuming the use of the software. And then we then had this other issue with the software, this particular software. And I'll just read this. If any system of cancer care paths can be used in this payment model, so if one were to imagine a payment model in which multiple other care paths, other systems and there are other software systems out there that provide care paths for cancer patients. Actually, there are quite a few. If a payment model was devised, which is not this payment model as proposed, but one could imagine a payment model that was devised that would include multiple different software so that anyone could do this in a clinically specific way, but that would not be this proposal. It would be a different proposal. So just sort of conceptually, we wanted to put that on the table. Criterion 6, ability to be evaluated. The PRT presumes the evaluation would compare historical to actual costs. This is, by its presentation, is a single site pilot. So we weren't thinking about an evaluation the way we often think about sort of national multi-site evaluations. We were thinking about how you evaluate a beta test of a new product. And so the plans to measure patient experience and the quality metrics, and in particular, a particular strength of this is their ability to measure variance from protocol. That is a highly attractive feature of this proposal. We did have some concerns about the challenges created in the overlap between this proposed model and the MSSP program, which, by the way, Hackensack is participating in. And the sort of how do you handle, as we've discussed in this forum several times, the overlap between multiple models that are running simultaneously. And then, again, the single site and proprietary software issue comes into play here. Integration and care coordination. Here, we just wanted to point out that due to the excellent work of staff and the data that we were given access to, we did find that cardiovascular conditions were overrepresented in this group of cancer patients, in at least 3 of the 4, and that this has implications for both the care coordination, that this is not, these are not patients with single discipline problems, and therefore you are, by definition, coordinating care across a multidisciplinary group. While there wasn't a lot of detail around that, there was certainly the potential with prospective payment and the incentive to deliver highly coordinated care. So I'll leave it at that. Well, I guess to the extent that the care integration is an inherent characteristic of a clinically integrated network and all providers involved were using the same EHR, both components described in the pilot that they described, the PRT did not have significant concerns around that issue. But you could imagine if this was not a single organization providing comprehensive care, there would be the potential for significant care coordination issues. On patient choice, this was the one that we did not feel it met criteria. We did as the transcripts will show of our conversations with the submitters, they did address this verbally and gave us some encouraging statements about how patient choice is incorporated into this. But we just want to really underline the point that in cancer care, patient choice is a very important piece of care, I guess as with all care, but because of the high morbidity associated with some treatment choices and the different perfectly acceptable choices that are presented to patients, we just wanted to be sure that once you're assigned a bundle, a payment bundle, and you're in the process, if the patient changes their mind about what treatment lane they're in, how does that affect the payment? And because it affects the lane they're in, we heard that from the proposer. They switched lanes, but we didn't have a clear understanding of how that affected the payment. On patient safety, here we thought this was a great use of health information technology to, as I've said before, really highly define and describe the delivery of cancer care. We did want to see, as I mentioned before, more verification of the pathologic diagnosis, at least some method of assurance on that score. And then health information technology, this was an excellent use of that. So I'm going to go back and summarize the key issues. This is a single site proposal. If a single site proposal is acceptable, and we'll get into this discussion, I'm sure, PTAC should consider whether and how the HMH CODA pilot study would yield information that would determine if expansion of the model is appropriate. Again, the proprietary nature of the CODA software brings up the issues that we'll get into, I'm sure, more in discussion. And then the total cost of care, is it a total cost of care model or an oncology cost of care model? And actually, there's both the conceptual issues there and then the practical issues there. And we look forward to the responses from the submitters and the discussion with PTAC. Thank you.
Thank you, Tim. I guess I would ask your colleagues.
I'm sorry, I would ask my colleagues to weigh in.
All right. As you know,
could you move the mic a little closer there, Bruce? Thank you.
The requirement is that each preliminary review team have at least one physician member. This one has two, which I think is a good thing because knowledge of the clinical care models and how this model contrasts with others in medicine generally is an important part of the model. I'm not the physician member of the team. The economics of it are also very interesting, and I just would like to point out one thing. The model and the payment system are based on comparing current patients with historic patients at the same site. And if, for example, Hackensack is a high-performing health system, which is, there's some evidence that that's true, they've taken on the responsibility of comparing current patients with historic patients and basing the payment system and the profitability of it, if you want to call it that, on their ability to improve upon care of their historic patients. From a more global standpoint, we'd probably like to know how the payment system would contrast not just with historic patients at that site, but with patients, cancer patients, more globally. And there is at least the possibility that that comparison could yield even greater savings than the ones that would obtain just at Hackensack. So and this is kind of a roundabout way of commending Hackensack for being willing to base payment on current patients versus historic patients when that comparison might not yield as much difference as it would if it was more globally compared to cancer patients throughout the healthcare system.
Yeah, I will say two things. One, I don't think, Tim, you mentioned that they are an MSSP recipient right now. So again, that's local to this organization. They have experience in managing comprehensive care. It was quite striking that for 3 out of the 4 cancers, the rates of cardiovascular disease were remarkably higher than in the average Medicare population. And so that is a real issue. And so I would just emphasize we would have to deal with the overlap in payment and not the double count savings. And so that's a technical issue that CMMI has had to deal with in other places. We would have to deal with that here as well. The second point, just to sort of summarize why we are attracted to this, there's been a lot of talk in recent years, going back actually many years, of precision medicine. This is an area where there is precision medicine. And so we are attracted to the notion of precision payment for precision medicine. And what this does do, and is consistent with how Medicare pays for other things like hospital care, is it passes through inputs and input prices. So I just want to read a couple of sentences from a response to the questions we asked them, which I think makes this clear. A bundled program does not discourage appropriate use of high-cost therapies if they improve clinical outcomes. In most settings, higher-priced therapies would be components of a separate bundle that would have a separate price. For example, one bundle of breast cancer would be anthracycline-based chemotherapy, and a different bundle would be anthracycline chemotherapy plus Herceptin antibody therapy. The bundles are distinct and do not compete with each other and can be priced separately. So we do not have a payment model a prospective payment model that would encourage the owners of the bundle to sort of not provide state-of-the-art care. We actually pass through that And, you know, we can discuss whether that's a good thing or a bad thing. We thought it was a good thing, that this is a very precise payment model. One of the issues then becomes how generalizable and easy is it for CMS to administer something like this on a national basis. So that's why we were attracted to the notion of a pilot. And we did, by the way, explore the potential that if it was successful in Hackensack, it wouldn't be a one-off. It could actually be adopted more broadly based on the lessons learned. We pursued that, but we, as Tim emphasized, we were considering this as like a pilot demonstration.
Thank you, Bob, and I just want to compliment the work of the proposal review team, Tim, your leadership, and working with the submitter, and your thoughtful analysis as a review team. I guess I would look at my colleagues on the committee if you have clarifying questions that you would like to ask of the PRT, Kavita, Len, and then Elizabeth.
All right, Tim, to the whole PRT, thank you. I think some of these questions can go to the submitter, but I just wanted to ask so that I could make sure, you mentioned the complexity of the payment methodology. I just want to make sure I understood some of the things that you talked about, because in their response to some of your questions, how the bundled price would be calculated would be based on that 3-year look back of, I just want to make sure I'm clear, because the novelty, which I agree, is with this unique staging and kind of the ability to match these bundles with like precisely what's going on clinically, but the initial pricing would be done on a 3-year look back of traditional claims data, I assume, based on Medicare data, which has none of these elements. So did you all discuss that?
Let me just clarify one point, and then that would be a good question for submitters. They have, because they've been using this system for the past 3 years, they actually can match, if they had the claims, they could match the...
You could do a cohort matching.
Exactly.
And kind of what I would do with SEER and match it to the claims. Right, okay.
Based on the individual, the costs at the individual patient level who were assigned to each of the CNAs.
But for another, I guess, well, you looked at it, this is the only site. Okay,
so
that's fine.
Exactly, the whole issue of generalizing that.
And then just to clarify, it's one of the high I'm not going to try to paraphrase, I think, what Paul said yesterday, where some of the weaknesses for one of the criteria where you actually did say that it met the high priority criterion. I believe it was 2, one of the 3 high priorities. You outline on slide and spoke pretty substantially through significant weaknesses. So can any of you just help me balance that? It's similar to what we struggled with yesterday.
Yeah, so I'll ask my colleagues to weigh in here, because we did struggle with this, but again, I'm going to emphasize what I said before and what Bob said, that we really applied the criteria to the proposal as a pilot. And having run dozens of pilots myself, there's no problem you can't overcome in a pilot, right? Because you're being creative and you make it work, exactly. And so while we have a long list of like very significant questions that would need to be answered if this were to become a generalized model, no question about it. The strengths that we saw for the reasons we specify, we basically said, we basically gave the benefit of the doubt on whether or not these problems could be overcome in a pilot to the applicant, and said, like, you probably could figure out a way to do this if you worked hard enough at it, despite the long list.
And then just one final clarifying comment. In terms of the patient, the criterion did not meet the patient choice, kind of how, in talking about what you just said, where oncology patients, this is one of the areas where flexibility, choice, and a lot of kind of patient-sensitive preferences matter. did you have a sense that, it sounded like in the application, then the questions, there was this kind of similar to MSSP and opt-out. The OCM, interestingly enough, does not have an opt-out mechanism. So did you engage in a conversation with CMMI directly about the current OCM program and just some of these issues of like not being able to opt out, for example, because you can't in that program? So one could argue that even CMS's own program doesn't have that kind of patient choice.
I think I'll maybe defer to Bob on this. I don't recall, we did discuss the patient choice issue, as the transcript shows, with the applicants, and we did talk to CMMI about OCM. I don't recall that we talked about the patient choice issue with CMMI. It's a good question.
I'll just make two comments. One is, as a co-author of a paper criticizing OCM for not having a formal shared decision-making, I was sort of knowledgeable about. Is that Friday night? You're going to read. Basically, the concern that some of us had, that I had, let's put it that way, was that the model seems so reductionist that for any patient, you could put in their genomics and their pathology and their stage and come up with the exact right treatment lane. The question is, where's the patient? I mean, you know, where's the shared decision-making about that? Again, in conversations, they seem quite attuned to the need for active patient engagement in making those decisions, but there was just a reductionist quality to the technology, and I'd still be interested in pursuing that a little more, is in a real tangible way, where does the patient choice come in? But we didn't pursue with CMMI the flaws in their model.
Thank you, Bob. Len?
Nice job, Timmy. So I'm going to focus on. I'm going to focus
for
on.
the audience. There's a lot of mutual respect, as you can see here.
So I'm going to focus on two criteria: payment and I guess flexibility or something. Evaluation. The way I would give advice to future PRTs, including those that I might lead, is we should be more verbose when explaining the benefits and more concise when explaining the weaknesses. That'll make it look more balanced on TV. But the truth is, the way I would interpret what you're telling us here is that you like the structure so much, you're willing to overlook what I would call the development cost of making this thing operational, even in the one case, right? So I guess what I start with is, why can't we settle this total cost of care versus oncology cost only? It seemed like, from what I read in the transcript, they're open to having it be total, so we're done here. I mean, I don't know how you could do oncology cost only given all those comorbidities and everything else. So I'm just, why is there still a question about that?
Well, and again, I'll ask my colleagues to weigh in here. I think, in part because the method for understanding total costs, it could be done for exactly the reasons that Bruce said. Understanding the non-oncology costs and the payment issues associated with those costs that are occurring actually outside of the Hackensack system and all that. So leaving aside the practical claims payment issues associated there. Like, how do those people get paid? Does it get deducted? You understand that there's some complexity there on the practical side of just implementing a model that has multiple recipients of payments, but one who got a prospective payment that's supposed to cover all of it. But aside from that, the conceptual issues that we were facing specifically relates to the uneven distribution of the comorbidities and how one correctly projects total costs of care with that uneven distribution of comorbidities. Do you see what I'm saying?
I am, and I guess I'm just, I'm a simple country health economist, and so you risk-adjust the bundle. How hard is this? I mean,
So,
we need the data to do the math. But
right. So I guess you can imagine that this gets into like some technical speak here, but variances inside the bundle could be really, really significant. And we haven't seen, because no one's done it yet, right? So we haven't seen what the intra and inter-bundle variances would be.
So you would say then, not to interrupt, but in your mind, it's not clear whether it would be better to go with oncology only versus some kind of variance-adjusted total.
Well, so yes.
Okay.
There's some
That's good enough.
in my mind, it's not clear. There's some technical issues. There's the technical issues associated with the practical aspects of payment. There's some technical issues around the risk adjustment and the uneven distribution of comorbidities. And then there is we haven't talked about this yet, but there's also preference, total cost of care for sure, be easier. It would eliminate the practical questions. But on the total costs of care, if you have 200 or 300, if you have a cancer center, and now I'm talking about generalizable model here, if you have a cancer center that's got 200-300 patients in a model like this over the course of a year, and you're taking on total costs of care, how many car accidents does it take before the bundle blows up on a total cost of care model? And that is this putting risk, apportioning risk to the participant that's unreasonable? And again, I don't know.
Okay.
Let me take a shot at that.
Okay.
At the last time we were here, we seem to have accepted from the American College of Surgeons in Brandeis that the new episode grouper could do just that it could, in fact, isolate the costs of cancer. Mm-hmm. Because they were proposing ultimately it could be done for procedures and conditions, and that the grouper had now been advanced to, I don't know that, but I think it's worth knowing. I can imagine this organization has done MSSP. They seem to be in a pretty good position to deal with total cost of care. There may well be other places that aren't, and Tim is raising issues around insurance risk and things that have nothing to do with cancer management. So I think there are some questions. I think we as a committee probably need to know a little more about that episode grouper and what its capabilities are. I'm skeptical myself.
But the inference I'm drawing is we should do the math both ways in this case. Okay.
Yeah.
Which gets me to, tell me a little more, and maybe I missed it, how much has been done already? Like, it seems to me once you assign a CNA to a patient population, somebody somewhere also knows the claims that go with each of those people. So there's got to be a mapping already between the CNA and dollars, and that's been done, I presume, at Hackensack. In principle, couldn't that be done for any patient population across the country? Because what I heard is the variables that actually are not in claims are in either the EHR or some kind of specific screener or survey or whatever that's done. So theoretically, you could construct, if you will, control groups outside the Hackensack world and make this thing much bigger. But I take it...
I think, Len, you just put your finger on why because we could imagine that you could do this.
Yeah.
We didn't see in the proposal the method to do that, but we could imagine it could be done.
Well, I was going to say, so my understanding of the proposal is basically they're asking to work with CMS to essentially do this, right? And if you did that, it seems to me, that's to say, if the keys to the kingdom were granted, shall we say, then one could construct non-Hackensack specific baselines. So you could take this larger much quicker than one might imagine, in the sense that one could do a national mapping from the CNAs to this, to the cost. No?
Well, It'd be good to hear from the proposer on
Well,
this specific
I
issue.
expect they're going to answer that
Yeah.
question.
But what makes it work at Hackensack is their ability to assign CNAs to their historic patients. And to do that, they have to have in their database on those patients a lot more than just Medicare claims. They have to have all of the elements that enable them to assign a CNA in order to establish.
So that includes EHR data.
Yeah.
And what else?
What's in the HR data goes far beyond what's in claims.
But that's obtainable in life, right, in other places.
Yeah, well, what did he say? Theoretically. So I think that's what we economists like to call an empirical question.
Okay. So, Tim, you talked about one of the complexities in imagining this future world would be, what if there were multiple competitors of CNA and they all had these different pathways, and good Lord have mercy, we can't have infinite number of bundles. Has the clinical superiority of CNA as a generator of clinical pathways been clearly demonstrated? I mean, is surely in a market test, some of these are better than others. We wouldn't have to put up with 300 of them. I guess I'm asking the question, it's proprietary, that's a black box to me. How good is it?
Yeah. So we had quite a bit of discussion on the PRT about this question. And I guess what I might do, Len, is defer that to the deliberation phase.
Okay.
Because I don't have any more than what we've already said. Because
so there's not been some meta-analysis to compare X versus Y?
No,
okay.
And this is just personal. I made some phone calls to people when we were doing this PRT about just the software that's out there. And there's a lot of software out there that is described somewhat differently, but and whether there's, how many late paths there are in the different pieces of software, but there are multiple versions of software out there that assign cancer patients based on demographics and genetic criteria associated with the cancer-specific molecular diagnostics to specific pathways, and then the software follows the pathways. So this isn't the only piece of software out there that does that. So one could imagine that since mostly they're all based off of the same set of professional guidelines that they all use, but what I'm doing is I'm assuming an enormous amount and saying that in theory, one could get to a point where you could either have multiple competing softwares, but a meta structure that allowed a payment model to use multiple different sets of, or that through some process, like the one that got us our single national EHR process.
Oh, that one. Yes. Okay.
You know which one I'm referring to.
The one that worked. Yeah.
But I'm hand waving here, right? Because none of this exists. We could imagine that it would be possible and actually beneficial, but we are, as a country, we're certainly not there yet, and this proposal is not proposing to get us there. Okay. But it is potentially a step in the process.
Elizabeth.
Thank you, and thank you to the PRT. Your excitement is palpable, and I think I actually have a less elegant version of Len's question, but to that point, reading their responses, there's a real tension between how generic this is versus how special it is. Even saying that anyone could do this using any tools or by hand, and that it is, the entire concept is, quote, generic in theory, but then that CODA's classification system is unique and special. So particularly in regards to scalability and what we heard this morning about not wanting to sort of limit ourselves to a proprietary tool, do you have a sense, and maybe you just answered this, that this could be done without CODA? Or is that sort of inherent to this being effective?
So I think, and again, I asked my colleagues to, particularly if they disagree, I think our response to this was it could be done, and that it would be good for patient care in the United States, oncology care, if it was done. But this proposal is not proposing to do that, right? I think it's a step in that direction.
All right, my question, as I read through the proposal, at face value, it talks about the bundle, that it includes unrelated services. The backbone of the platform for this proposal is that there's a 3-year look back for the costs associated with these 4 tumor types. They talk about outliers. They talk about stop loss that impacts 2 times the bundle, and then those folks are considered outliers. So I'd like to, I don't know if you had a discussion that might not have been captured in the transcript about that. And my specific question is, when there was 3-year look back, was that same methodology applied? Were people, based on the performance, where they stripped out when they set the price, if you will? And that may be a question for the submitters, but it wasn't clear to me when I looked at the model. And then when these folks become outliers, who bears, where does that expense go, and how is that sort of determined and addressed? So those were questions that, again, I don't expect necessarily that you would have the answer as a PRT, but perhaps you had that discussion with them.
I don't have the answers to those questions, but I would, given the frequency with which my colleagues have answers to questions that I don't have answers to, I'm going to defer to them.
And I'm going to defer to the economist.
You know, you're every bit as much an economist as you are a doctor. You know that. Well, 2 things. One is I can't remember specifically, but you have to use the same methodology in the look back as you do in the prospective pricing. You can't include the outliers in calculating historical costs and then strip them out of the payment. So it has to be symmetrical. Second, they propose removing outliers, and we said in our PRT that we thought a more sensible approach was Windsorization, which means you don't remove the outliers, you just you drop their cost down to a threshold. And once again, you would have to do it in the same for the historic as the prospective.
That in our conversation, when we brought that up with them, they were very open to that change.
Thank you. Harold?
I have a number of questions for the submitter, which I'll ask them, but the question I had for the PRT was, I searched in vain through all the material to understand exactly how the quality measures would factor into the payment model. There was an extraordinarily long list of quality measures, which is great, usually leads to people saying, no, you can't possibly have that many quality measures. But I couldn't figure out anywhere exactly what impact that would have on payment. There was references to careful monitoring of quality, et cetera, et cetera, et cetera. And I mean, you can give the patient the exactly right evidence-based treatment and do a horrible job of managing their symptoms and have them ending up in the ER in the hospital constantly. And there are some measures in there, but it wasn't clear to me what impact that had. There was a reference in the August 30th response, which, of course, we all had a huge amount of time to read, but on page 15, and again, the applicant may also have, but I wanted to see if you guys thought about this. It's at the very end of the page. It said, of greatest importance, the bundle program first requires achieving an expected clinical outcome based on evidence. Only after achieving that outcome would shared savings be available as determined by the impact on the total cost of care. Now, I did not see, and again, I searched back, I did not see any reference to this being a shared savings model. It was a bundled, flat, fixed prospective price model. With, I did not see any adjustment to the payment amount based on quality. There were some very, very small references to the notion that somehow the individual physicians might get something, but there wasn't anything overall. So I'm curious as to whether you saw something I didn't, and whether, because you didn't comment on whether on the kind of the quality aspects other than the stinting on actual treatment.
So, Harold, as usual, your acumen has identified a lesion in the PRT's process. Lesion? So I will have to ask the submitters, but I do not recall that there is a relationship between the CMS payment for the bundle that is modified by any quality. But I to a couple of points though. One, they did actually describe how they intend to pay internal to their organization, and that they would pay physicians, for example, the Medicare fee-for-service rate modified by those physicians' performance on their individual, because you know, when you have patients that are entered into a software system, and on every single patient you can measure variance to the protocol, you can at the individual physician level provide incentives, right? And so that is that's a rather remarkably, as to use Bob's words, precision payment, internal. But I will say I do not recall that there's a modification to the external payment. I will say on your shared savings, I think my own understanding of that is that is a loose use of language. I think as the model is, as you described, a fixed payment, and if your costs are under that fixed payment, you reap the savings. They described it as a shared saving. I'm not sure that's not the same understanding of the term shared savings that we would normally use in a federal payment model, and that the risk,
because in that case it's not necessarily shared.
That's correct, except to the extent that the priced bundle itself presents savings to CMS, and as we described, right? Okay.
And then just one follow-on question. In terms of the physician compensation portion, did you focus on that at all, and did you have any opinion about whether you thought that was, it sounds like that was not, from what my reading of it, that was not integral to the model in the sense that one wouldn't be required to compensate physicians in a particular way if you were in the model. That was kind of up to the, again, we understand this is one site, but that would be kind of up to the site, and it would be potentially could change that at any point. But did you have an opinion about that or not?
Yeah, so Harold, again, your acuity is right on target. So in general, we thought how you pay physicians underneath that's up to them. But we did have a discussion about one thing that raised a concern with us, which is in our report, but I did not highlight in the slides. And that is, if you are incenting individual physicians to not be at variance with the protocol, what happens when the best thing for the patient is to be at variance with the protocol? And we did actually have a discussion on the PRT about we thought that could be mitigated with we actually, I think, described in our report 2 mitigation strategies for that. One was that you could minimize the penalty, just not make it an onerous penalty so that there wouldn't be undue incentive on the physician, or that the physicians, and this is the way we do it in my organization, the physicians actually have an explicit method for explaining a variance and getting out of the penalty just through a peer-reviewed explanation. Or you can imagine several different models for doing that.
Can I add to what you
Please.
said?
Please, because I'm currently, in that answer, practicing economics without a license.
When do I get to practice some medicine? That's what I want to know. Another part of our discussion was yeah, and I agree that underneath the payment system, the compensation of individual practitioners is an internal issue. However, if you're going to continue to compensate physicians on a fee-for-service basis, which carries all the incentives that we have talked about for years, it seemed to me that you need to have a strong integrated delivery system to govern what physicians do and don't do, and part of that, of course, is adherence to the model as it was designed.
Just one closing comment. I guess my observation, though, is that one of the theoretical advantages of doing this in a physician group would be the averaging and across a number of patients, so you would have more flexibility to be able to treat some patients differently. If you then sort of throw that all away and go down to the individual physician level and say you're sort of accountable for the spending on your particular patients, you have lost that. And one of the general arguments for having a large physician group is you would pay the physicians not on a fee-for-service basis. So at any rate, so that, I think that's one issue in terms of how this all gets translated.
Okay, Paul.
So I have one specific question, but just to add on to the provider financial risk, just a comment, because in their proposal they say, you know, that the physicians don't take downside risk, but if they don't meet performance and quality standards, they'll be asked to exit the team, which, you know, was, I guess, concerning, potentially problematic. I don't know, did you have any discussion amongst the PRT around that whole?
We did have a little discussion about that, and I think, and this is one of the things that happens when you're reviewing a proposal like this. So that's covered in, you know, one sentence in a very long proposal. To unpack that to a significant degree, which we did a little bit on the phone, there's a lot, as you're pointing out, there's potentially some problems underneath that. But in general, again, I don't want to speak for my colleagues, I'll say I viewed these as, this is the kind of stuff management of an organization has to deal with every day, and we're just going to assume that they're going to do right by the process. They have a strong incentive to keep people in and functioning to deliver care to their patients, and so we didn't think there would be much incentive to sort of willy-nilly kick people out. That would be a sort of a somewhat self-destructive management technique. But we did take note of that that line of the proposal.
Great. Actually, my one specific, I may have missed it, I apologize. You know, in cancer care, a lot of patients are on research protocols. And I couldn't see, are patients who are on sort of the NIH protocols, are they excluded from this, or how does that work? Is there any mention? Did I miss that?
That's a great question. I hope you ask it of our submitters. I think actually we made just an assumption, since research protocols are by definition highly protocolized, right. I assume that the lanes are themselves, where appropriate, protocol lanes. I guess I never asked the question, so it's great that you asked the question, but just made the assumption.
Okay, well, just thinking that there may be, whatever, additional testing, that's part, yeah, additional costs related to a, whatever, research protocol that.
Yeah, well, I mean, just as a matter of course, research protocol services that are not billed, generally academic medical centers have accounting systems that separate the bill paying. And so since I would say it was true before the bundle was introduced and true after, and so it's a constant that flows through, so shouldn't affect the pricing. But again, that's not a conversation I had with the
Again, that goes to the site-specific nature of this, as opposed, because in a general, Well, I understand that for in general, but
Yeah.
I was just trying to think more broadly if places hadn't been involved and now they're involved in research, you know, that again, related to the historical.
It's a good set of questions that is raised by the point you're raising.
Kavita.
Just a follow-up question. Did you all talk at the PRT level about kind of this total cost issue that you wrestled with? I'm assuming post-acute, hospice, all of that. I mean, we're talking true total cost. And then if a patient switches, which is entirely possible, kind of you overlap enrollment periods and they go from fee-for-service into MA, I'm assuming kind of private Medicare plans are ineligible, but is that, I couldn't see that also. It's just that, did that come up at all?
It did not come up. I guess I would put that under the category that Bruce, which is CMS has ways of handling those situations, but that would happen. In real life, in this process, you would get a patient who is halfway through a protocol, halfway through their year, and they would sign up for Medicare Advantage. I assume the way it works now with all the shared savings programs is they're out of one and they're in the other. Yeah.
Any other questions for the PRT from the committee members? Comments?